As Santosh says, in my day job, I'm an innovation consultant. And what that means is I help big companies solve scientific problems. I work with companies in pharmaceuticals, in medical devices, in consumer goods, in food, in apparel, in footwear, in energy and transport. So lots and lots of different sectors. And in order to solve these problems, I work with colleagues from a wide variety of backgrounds. So not only medics like Isa, but also biochemists, physicists, chemists, behavioural scientists, designers and engineers. And what I find time and time again is that when I'm looking at a particularly challenging problem, talking it over with people who have a different perspective and a different training from myself makes it easier to see a way in. And that is why I wanted to come and talk to you this evening, because I wanted to talk about a problem that you may be so close to, you don't even realise what a problem it is. And that's the problem that in our society, childbirth is painful, it's traumatic, and it's expensive. So hopefully in the next half hour, I'll give you a few new perspectives on this problem. Now to start with, I'd like to find out a little bit about the balance of the people that I'm talking to. So please could you put your hands up if you are a medic or if you're training to be one. Okay, pretty good, right. So how about if you're a veterinary surgeon or training to be one? Yeah, okay, so we've got a few vets, good. And is there anyone here who is neither a vet nor a medic? Fantastic, welcome, it's lovely to have you. Now I'm also making the assumption that a lot of you here will probably be too young to have already embarked on your own reproductive journey. But for those of you who have, there may be a few points in here that are a little bit hard going, but bear with me, we'll move through them quickly. So, I want to start on a topic that is quite confronting, and that is the topic of abortion. But not abortion as we define it typically when we think about it in a medical context, but actually how we define it when we think about it in a veterinary context, which is the spontaneous delivery of a dead or non-viable fetus before pregnancy is complete. Now, think about it, as vets, we actually have very little information about what's going on inside a mammal's uterus, right? We can do ultrasound scans, that's how we diagnose pregnancy. But for the rest of that pregnancy, we can't ask a mammal whether she's feeling okay or whether the baby's moving. We just have to take it on trust that everything is okay. And that means when something goes wrong, it's often a very, very long time before we understand that something has gone wrong. So either we might find out if the mother gets sick or if she spontaneously aborts the fetus. And that means because we have this longer window, we often see fetuses that are in different stages of decomposition, in effect, inside the uterus. So sometimes we see fetuses that are broken down and stinking, we call that maceration, or we see fetuses that are hard and desiccated. We call that mummification. Now, 18 months ago, I went to the hospital for an ultrasound of my third baby, the 20-week ultrasound, and on that scan, my baby didn't have a heartbeat. And I was devastated. And so I went into the hospital. I was scared of me getting sick. I was scared of what the baby would look like. And I was scared of having my labour induced, because induced labours, which are labours that are triggered by drugs, are typically harder and more painful. So I went into the hospital. I remember the fear, I remember the antiseptic, I even remember the kind of patterns on the lino. And 6 hours after I had the drugs to make my uterus contract, I gave birth to my baby's body in a little tiny toilet cubicle with the door closed against the world. And I couldn't give birth to my placenta. And the drops of blood became a stream, and the stream became gushes and pools. And eventually the midwives brought the IV fluids and the drugs and the doctors. And an obstetrician reached into my uterus and removed my placenta. And the bleeding stopped. Now, I am a mammal. But for that experience, I was so grateful to be a human mammal. Because I was grateful for the drugs, I was grateful for the gas and air that allowed me to dissociate from the pain, and I was grateful for the skill of the doctors. Now I'm going to move on. I want to tell you about some really cool veterinary reproductive strategies, some fascinating pieces about how animals reproduce, but I want you to remember that story. Before I start again, I'm going to ask you to put up hands because I want to know your experience of seeing different sorts of mammals give birth. So, and I'm looking at the vets on this one. Can you put your hands up if you've ever seen a lamb being born? Great, quite a few. There are some mullets too, fantastic. How about a puppy or a kitten? Yeah, quite a few. And who has ever seen a human baby being born? Great, good. Okay, so if I wasn't limiting myself to mammals, I could tell you some really, really cool stuff about different reproductive strategies in non-mammal species. Maybe I'd tell you about the spider that lactates to feed her spiderlings. She produces milk for baby spiders. What? Maybe I'd tell you about the seahorse, in which the female seahorse lays her eggs into a pouch on the male's abdomen and the male is pregnant. Or I'd tell you about the gastric brooding frog who lays her eggs, swallows them, gestates in her stomach and vomits up the babies when they're ready. But nature is crazy, right? And then if I was going to talk about mammals as well, I can talk about monotremes, mammals that lay eggs, that is pretty crazy. But I could also talk about marsupials, the kangaroos that give birth to, in effect, an embryo without even back legs. It does the journey of a lifetime right up through its mother's fur to spend the rest of its, in effect, gestation in her pouch. Or, given that a lot of you are medics and so may not know this, I could just get some cheap laughs and I could tell you that a male pig's orgasm lasts 10 minutes and it produces a pint of semen. Nature has some crazy reproductive strategies. But I'm limiting myself to relevant things around birth. And if you think back to that story I told you at the beginning, I suffered from a postpartum hemorrhage. And this is something that's actually very uncommon in most of the animals we deal with. And that comes down to some particular beauties of placental biology. Now, I'm sure you all remember that the placenta in many species is an organ that produces hormones that sustain pregnancy. But it also brings together the maternal and fetal circulations really, really close to allow for the diffusion of nutrients and waste products. But I'm sure you also remember back to first year physiology that the rate of diffusion is affected by certain variables. So it's affected by wall thickness and surface area, among others. And different species have evolved in different ways. So actually, if we look at a horse, we compare it to humans. Humans have very little distance between the two circulations, which makes our placenta very efficient in terms of surface area. Horses, by contrast, have about 6 layers of cells in between those two circulations. And what does that mean? It means that for a horse to be able to give enough nutrients to its foal, it needs to have a placenta that covers its entire uterus. A horse placenta is massive, I could probably wear it. But this also affects different things. How about if a horse has multiples in a pregnancy? If it has twins? Well, there's not really very much real estate. And that's why horses almost never have twin pregnancies where both animals survive. It also means that we're talking about big molecules like immunoglobulins. The transfer between those circulations is pretty poor. So when a foal is born, it has almost no immunity. And that's why it has to drink 1.5 litres of colostrum in the first 12 hours. That's a huge amount, but that gives it the immunity. That is what has evolved to allow the horse to evolve for a certain niche. So there are lots of differences between placentation, for example, but actually the fundamental processes of birth are pretty conserved between all mammals. And they rely on 4 different hormones. First, you have oxytocin, the hormone of love, of bonding, but also the hormone that's released in a surge about 24 hours before labour starts that crosses the placenta, crosses the immature fetal blood-brain barrier and helps to prime the brain to cope with the potential hypoxia of birth. Crazy, right? So cool. And then it's released in these surges that drive uterine contractions to help expel the baby, and then afterwards it helps the mother to bond with that baby. So that's the role of oxytocin. And then we have beta endorphins, the reward hormone, the joy hormone, the pleasure hormone. And these are quite low through labour, and they start to ramp up as the contractions increase. And these create this altered mental state, which is a hallmark of physiological birth in humans. And it also means that when the baby is born, the mother's reward on seeing that baby is enormous, driven by that hormone. And that hormone's even released in breast milk for the first 4 days. So every time the baby feeds, the baby's like, wow, this breast milk is amazing. Crazy. And then we have catecholamines, so adrenaline and noradrenaline, the hormones of excitement and fear and flight. And actually, these are at really, really low levels at the beginning. They need to be low so labour can get established. But once labour is established, and once you get to the point where the cervix is about to open, you get this massive spike of noradrenaline and adrenaline, which helps to clear that kind of that altered mental state, that fog of that sort of labour place. And it means that when the baby is born, the mother is absolutely on it and able to attend to what it needs. And then finally, you've got prolactin, the hormone of breastfeeding and milk production, quite low during labour, and it has a spike a couple of minutes after birth, ready to drive that milk production and drive that breastfeeding. So we've got these 4 hormones in all mammals, and they are important when they work in the way they're supposed to work. You end up with physiological mammalian birth. So I said, okay, we've got placental differences. We've got these hormones that drive on physiological birth that are actually very conserved. But then what comes out can look really, really different in different species. So, hares and rabbits, right? Okay. I mean, even the medics, I'm pretty sure you probably have seen a hare and rabbit, kind of like long ears, whiffly sort of noses, whiskers. They're pretty similar looking. But their neonates look totally different. So baby rabbits, tiny, bald, hairless, basically can sort of wiggle a little bit, barely move. Pretty sort of, pretty underdeveloped small neonates. Hares, by contrast, are gorgeous. If you're having a bad day and you think, oh gosh, I just need to see something really, really cute, Google newborn baby hare, because they are adorable. They are born fully furred and they're just ready to go. And this is because rabbits live underground and hares do not. So the rabbit digs herself a burrow, gives birth to a litter of kittens. She then leaves, closes the nest with a little bit of grass or fur, and she only visits them once every 24 hours, and she kind of leaves them to just get on with it, underground where no one can get them. Hares, they don't live underground, so they make this beautiful neonate. Their gestation period is 42 days as compared to the rabbit's 30 days. So they give birth to something that they can hide in a little hollow in the grass. And when a hungry fox comes along, that little hare has at least got a fighting chance of being able to escape. So, I mentioned that the fundamental hormones of birth are conserved across the mammalian kingdom. And these hormones are produced by the limbic system of the brain. And certain structures that are associated with the kind of early mammalian brain to differentiate it from our logical, rational thinking neocortex. And for these hormones to be produced, for the limbic part of your brain to work effectively, there are certain conditions that all mammals seek when they are looking for somewhere to give birth. They look for a warm, dark, quiet, familiar place, either alone or with familiar others. And when these conditions are met, birth can be very, very straightforward because mammals have a reflex called the fetal ejection reflex or Ferguson's reflex. So when you have a cervical stretch, this causes oxytocin release, which drives further uterine muscle contraction, which drives further cervical stretch. And when this reflex works very well in humans, for example, it's characterised by a very short second stage of labour. So from complete cervical dilatation to baby being born is usually 1 or 2 big involuntary contractions, usually reported as painless. So this fetal ejection reflex can be blocked in a couple of ways in mammals. So one thing we can do is we can make the neocortex really active. So if we scare a mother, if we stress a mother, that can inhibit the limbic system activity. So For example, mares, female horses, if you stress a mare when she's giving birth, she can just stop. And 3 days later, she can decide to have her foal. And that's a fantastic evolutionary strategy, right? Clearly, if she's really scared, it's not the time to pop out a sprog. She might as well just sit tight and wait. So, but what is neocortical activity suppressing the limbic system? What does this really mean? What does this really look like? Well, I'm going to give you a little bit of homework. Next time you're having sex with a partner and you're both approaching orgasm, pause for a moment as though you've been thinking about it really hard and say to them, what do you think we should have for dinner tomorrow night? And I can tell you, you will see firsthand the effects of neocortical activation on the limbic system. So, we can inhibit that fetal ejection reflex at the top by stimulating the neocortex. But we can also block the signal from ever getting up to the brain in the first place. And that's how we block it with an epidural. So, when birth works as it should do in mammals, we have a very fast second stage of labour. We have hormones that drive bonding and pleasure and lactation. And we have what's often described as a very good experience, even by people who've had physiological births. And this seems like there's a lot of evolutionary mechanisms to try and help birth be straightforward. Kind of makes sense, right? You know, physiological birth. There are lots of efficiencies that have happened, that have evolved during the process of birth to try and optimise long-term neonatal health. So, I mean, babies are all kind of wet and full of fluid, right? Great. You squash them through the birth canal, you squash out that fluid, you make them more likely to be able to breathe. But you also help to stress them in just the right way, just as they need at that point in the development of their stress response. We need babies to have the right sort of bacteria on their skin and in their gut. And great, they go through the vagina, fantastic, we're inoculating them on the way out. And we need mothers to be able to lactate, but also to bond with their babies and to be able to mother them as well as they possibly can. And these hormones of birth help to drive that profound neuroplasticity of the mother when she has a baby, because your brain basically reorganises around this new individual. Fascinating. But there's one species in which we routinely ignore the need for physiological birthing, and that is in humans. Most people give birth in hospitals, in bright, cool rooms, where they can often hear the noises of other people in distress, they can smell the smells that we associate with hospitals and being ill, and they have people they don't know coming in and out unpredictably. That's a really, really hard place for a mammal to give birth in. And this is really problematic because the hormones are not in the right place. If we think about what mammals look for, we might think, midwives, they're really important, and we'd be absolutely right. We have midwives because these are people who try to help women and birthing people to have physiological births. This is great. In the UK, birthing people, pregnant people, see midwives throughout their pregnancy to talk about health and to plan for the birth. And then often they have births in midwife-led centres. So these are buildings with multiple rooms where midwives can look after a lot of people in labour at the same time. And this sounds great. Midwife-led birthing units typically have, beautiful double beds and hot tubs and mood lighting. They try to not look like a hospital. But there is a problem. Can you put up your hands if you have ever or currently own a dog? Okay, great. Now put your hands down if your dog is male. So keep your hands up if your dog's female. Okay, so we've still got some people with female dogs. Great. Now think about your dog. Probably lives in your house. Imagine she is heavily pregnant and she's looking for a place to give birth. Don't tell me, but just think about where she would choose. And think about how she'd feel if you took her to a midwife-led birthing centre, even if it had the world's best dog beds. She's a mammal, lives in your house, and her preferences are aligned with what mammals need. So, the problem is because we don't value physiological birth appropriately in humans, we don't see what happens when we don't create the conditions that enable it. So, I mentioned that we have midwife-led birth centres, great idea. Of all of the kind of hospital environments, they're probably the single one that is well set up to try to enable physiological birth. And now each of you, I want you to think in your minds, think about what percentage of births you would expect to take place in a midwife-led birth centre, given that it is the place that is recommended for all low-risk birthing people. Have a think, just picture that percentage in your minds. I'm going to tell you that at the Rosie Hospital, Addenbrooke's in Cambridge, 50% of births are either through caesarean section or through forceps delivery or suction delivery. 50%. 1 in 3 labours is induced. Now think about that percentage that you're envisaging in your minds, and I will tell you that 15% of births take place in a midwife-led unit. From a veterinary perspective, that is crazy. That is just so surprising. So, that is the cost that we pay when we don't create the right conditions for a mammal to give birth in. And I can tell you all sorts of statistics about how things are now, but how do we find statistics about how things could be? What is the value of birthing people up to have physiological births? I need to look at a population of people that birth in quiet, warm, dark, familiar spaces, either alone or with familiar others. And this is a population of people who birth at home. And if we look at home birth, we see that if you birth at home, you are just as safe, you and your baby are just as safe as birthing in a hospital. But you are 3 times less likely to need a caesarean section, forceps, or an episiotomy, which is a cut in the perineum. You are less likely to bleed, and you're less likely to tear. Your baby is less likely to be born ill or to require neonatal intensive care admission, and you're twice as likely to breastfeed. This is clearly also much, much cheaper. And that is the value of getting physiological birth right. Now, you're probably going to think, oh gosh, how's she going to wrap this up? How's she going to, tell us what to do? She'll probably say, vets have it right, you should just listen to vets and everything will be fine. But I'm just not that arrogant, because we vets make mistakes too, especially when an animal is particularly rare or particularly valuable. We forget that the best thing to do is to set the environment up for success, to watch unobtrusively, and to intervene only if necessary. So I think there are a few things that we could do if we wanted to treat birthing people a little bit more like birthing mammals. One of the things that we find is especially challenging as vets if we're trying to establish a captive breeding population of a wild animal is to try to recreate cultural mimetics around reproduction. And what do I mean by that? Well, when an animal reproduces, not all of its knowledge is instinctive and genetic. Some of it is handed down generation to generation. And so we have to try and get that back into a population in which it's been lost. So how do we do that in humans? Well, we make sure that everyone who's involved in birth work, be those midwives, be those obstetricians, we make sure that they have seen physiological, undisturbed human birth, because they need to know what they're aiming for. And you're probably going to say, hang on, undisturbed, how do we have anyone there? Well, that is the beauty of YouTube, my friends. There are plenty of videos. People love uploading videos of themselves giving birth. So there's lots of resources to have a look at. And we create communities for people, for pregnant birthing people, to share good stories and to say what can go well, because then, when the first contractions of labour hits, the first thought is not of fear and pain, but of excitement and anticipation. And we normalise societal discussions of birth that goes well, so the people who are coming after us have at least got something better to aim for. So we recreate cultural mimetics. We also need to appropriately weigh up the risks of not intervening with the risks of intervening. And I think actually vets do have a little bit of an unfair advantage here, because if I was talking to a farmer and I say, I think we should do caesarean sections on 40% of your cattle, then I'm responsible for those individual animals from their birth through to their death. And so I can see the consequences of the actions I take in the longer term. I might see, for example, that I have mothers that don't lactate as well, and that are in pain and not as well able to mother their calves. I might see the effects of the abnormal microbiota on their young animals as those animals grow up. And then when those mothers want to get pregnant again, or we're trying to get them pregnant again, then we may see problems getting them into calf. And if they are then pregnant, we might need to do more next time they give birth. So I'd see the problems racking up, and if the population of the herd was big enough, we could start to see the fact that caesarean section is associated with a 3 times higher maternal mortality rate. And my farmer is going to be reeling under the bill because this is crazy expensive. And finally, what we can do is we can set up birthing people for success. And that means first thinking about the physical environment, thinking about setting up something that is warm, dark, quiet, safe, familiar. And that means, for the majority of women, birth at home. And because we have to remember that birth in hospital, trying to give birth in hospital, is a bit like trying to have a poo on stage. There may be a few people who can manage it, but I can tell you that for the vast majority, it will be more comfortable, more satisfying, and profoundly less stressful than trying to do it on stage. Right, we're almost there, folks. And I still reckon there are a few of you in this room who are sitting there thinking, gosh, she's telling a great story, but I just have been that awkward medical student at a birth, and it looked awful. I cannot imagine how that could possibly go better or be a better experience. So I want to finish with a story. 5 months ago, I went into labour. It was a Monday morning and my contractions started, and they were about every 10 minutes. Didn't really hurt, they just told me that my body was getting ready. I was really excited. And I thought, great, my baby's going to arrive today. And Monday afternoon came round and nothing really happened. So I went to bed and I woke up the next morning and about the same situation. So I had another day. I thought, well, I'll go for a walk, that might help, I'll do some baking, do some cooking, and no baby. Wednesday, I woke up again. And ironically, before I'd gone into labour, I'd read about precipitous labours, which are labours where the baby comes really quickly, and I thought, gosh, I don't want to have one of those actually, because it's pretty cool. I've had previous births, I've really enjoyed them, and I want to make sure I enjoy every stage. Wednesday, cooking, baking, walking, nothing. Thursday, cooking, baking, walking, nothing. And on Friday morning, I woke up and the contractions were a bit stronger, and I said, oh, great. So I went into my 4-year-old's room and I said, look, I think the baby is going to arrive today. And she looked at me and she said, Mummy, the baby has not come on a lot of days. And she was absolutely right, the baby didn't come on Friday. So on Saturday, I thought, oh, well, got another day, cooking, walking, baking, the freezer's looking pretty full at this stage, but my parents-in-law came round for breakfast, and I'd seen them most days and for the previous few weeks, and I just didn't really want to see them that day. I thought, oh, I'm going to have a quick breakfast, and I'm going to take myself up to my room. So I sat in my room, did a bit of dancing, nothing really happened, and after a few hours my husband said, look, I'm still not going anywhere, should we go for a walk? So went for a walk, came home, and then at about 2:30, I could feel the world was starting to feel a little bit woozy, and it feels like you can pay attention to about this much around you, but everything else is quite fuzzy. I go from wanting music with words, because I like being able to understand what people are saying, to actually wanting music without words. That's the shift that comes. And then over the next few hours, my contractions got stronger. And so I wiggled, I walked around the room, I pulled on a rope that was hanging from the ceiling. And at about 5:30, I suddenly thought, oh, the next contractions are going to be horrible. And this is a stage called transition. That is the point at which the noradrenaline peaks and it clears the fog. And it's a point that women typically associate with feeling quite scared. So I said to my husband very quietly, I think I'm going to need a hand with the next few contractions. He said, oh, okay. So he shook my legs as I had another couple of contractions. And then suddenly, just as I had in the previous labour, I felt my cervix open. Weird feeling. It's like a kind of lurch, and the baby kind of goes, whoop. Oh, that's pretty strange. I thought, okay. But before I had really any time to think, I had another massive contraction. And I mean, I'm pretty sure that most of you have probably vomited in your life. And you know that kind of noise you make when you're retching and you have an abdominal contraction that forces air past your larynx? You make that really funny, like, noise. That is the noise of labour, my friend. It's vomiting downwards. So I made one of those funny noises. And I said to my husband, I put my hands underneath, I said, I can feel the baby's head. And he said, at your cervix. I said, no, in my hands. He went, no. And then suddenly another massive contraction, funny noise again, and baby. There's a baby on the towels underneath me. And I picked her up and I said, oh, it's you. You've been inside me for 9 months and I didn't know what you were like, and you're here and you're beautiful and you're my baby. And I turned to my husband and I said, we've got a girl. He said, I know, I've seen it on the scan. But I didn't know. But that feeling, that glory, that enormous joy, I just loved everything. I loved my baby. I was so happy. And actually, as the time went on, when I had problems feeding in the neonatal periods, when I was up at night with a baby that wouldn't settle, that joy and that glory of the birth stuck with me right through, and it made everything better. It was one of the most incredible experiences of my life. I am a mammal, and for that experience, I was so grateful to be able to birth like a mammal. Thank you.
Thank you so much to Gwen for such an interesting, humorous and eye-opening talk. So we're now going to open up the floor to any questions anyone might have.
Yes. Yeah, so that's a really great question. So your question is, have we evolved past the point of being able to have physiological birth? I think that's a really useful question, one that I was hoping people brought up, because there are lots of things that have changed in our society, and certainly it's one of the concerns that people have with where we're at now. However, what I find particularly interesting is if you look at high-risk populations, so these are people who, have a high BMI, for example. High-risk populations, the risk at birth to those people is higher. They're more likely to have adverse events than low-risk pregnancies, and that's what you'd expect, right? But what's really interesting is that when you look at people in those populations who choose to birth at home, you still see better outcomes, even if those high-risk people are birthing at home, than you would if they birth in hospital. Which says to me that, yes, we may have populations where things are harder, but in some ways, maybe that just means it's even more important to set up the conditions to facilitate success when you know that there are already, headwinds against you. Does that answer your question? Yes. So I haven't read up a lot on what's happened there. I think one of the challenges that we have generally when we're thinking about intervention is that when we look at individual cases, actually by the point they need intervention. It's actually much more about what is happening right upstream, right at the beginning, and how can we divert them away from that intervention. So one of the things that is also topical, you may well have seen, is that the cap on the numbers of caesarean sections has been removed. So before trusts were rewarded for sticking to a caesarean section rate of below a certain percentage to try and incentivise people not to do caesarean sections, because the WHO says that in a well-run maternity system, caesarean section rate should be below 10%, because when you can start to get over that, the costs of the caesarean section rate start to outweigh the people that you're saving. Now, one of I think the misaligned incentives on that one is that when you have a cap of no more than 20% of caesarean section rates, what you're really doing, therefore, is you're probably going to try and dissuade women who are choosing caesarean sections electively because you don't feel you have control over changing the ones that are happening as emergencies. And I think that in order to bring down the caesarean section rate, you can't do it by denying women choice, because ultimately the reason we're in this place is that we haven't recognised what women need. I think the way to do it is to change, to enable, to discuss and let women choose differently rather than having a set rate. Now, I may not have answered your question specifically around Shrewsbury and Chelmsford because I don't know about it, but that would be my slightly sideways perspective. Does that answer your question?
Thank you.
Yes. We have to differentiate between intervening at the right point for the right people and intervening with a lot of people too soon. So it's what the WHO says, the balance between too little, too late intervention and too much too soon. And so I would say that there are certain obstetric situations that I think, potentially both of us have experienced that require obstetric help, and they require it to prevent either the death of the baby or the death of the mother. And so those are the ones where we really need skilled obstetric help. But what we need to make sure is we're not, in effect, throwing baby out with bathwater and putting everyone through that process, because we end up in a situation where we're doing too much intervention and we're almost creating the rod for our own backs, where we're having a system that is overwhelmed, is under-resourced and is struggling because we are applying inappropriately techniques that are life-saving in the right situations to the wrong situations. Does that answer your question? Yes.
Just to follow on from that, if you look at maternal mortality in the UK, there were tremendous falls in the rates until about 1980, and the rate has been pretty static since then. Whereas if you look at caesarean section rates, the caesarean section rates really have gone up tremendously since 1980, without obvious benefits in maternal health.
Exactly, yeah, I completely agree. I fully agree, and it's actually one thing that I haven't touched on very much in my talk because I wanted to keep it very veterinary. But I was speaking to an obstetrician friend of mine about sort of, I'm going to say misaligned incentives because that's not blaming doctors. That's just we are in a culture which does not incentivise and facilitate good outcomes for good outcomes for mothers and babies, especially in the long term. And there was recently a Royal College of Obstetricians and Gynecologists webinar in which she just texted me a quote from a US surgeon to say, look, this is what I'm talking about, which was, the US surgeon said, talking about caesarean sections, he said, you pay me more, you don't sue me, I don't worry, and I'm done in an hour. Now, none of these are around optimising maternal and fetal health, but these are very real drivers of behaviour. And if we just overlook them and we say, oh, you should be entirely altruistic all the time, this isn't how people work. And actually, certainly behavioural scientists at work would say that. But I do think that if one of the things that I think is particularly important or significant in driving caesarean section rates is that we have a consent form, right? So people are much less likely to sue if they feel that they have consented to the risks. But we don't have a consent form for vaginal birth, which is kind of obvious because it's something that you're not having anything done to you. But actually in the same way, what I think that does is it makes medical professionals feel really quite acutely vulnerable of something going wrong in that process and then them being blamed. So I don't quite know how we get to a point where medical professionals are adequately protected from this so people can make better decisions based on maternal and fetal outcomes rather than on very significant drivers of behaviour. Yeah. Well, for me, one that stands out, and again this is quite a negative one, is that the evidence suggests that 30% of women, or people who've given birth, feel traumatised after birth. And that sort of persistent thoughts, that's night terrors, we're talking about very significant adverse effects on mental health. And that is shocking to me. 1 in 3, that's horrendous. And so this is a very negative one, but actually, just whether or not people feel traumatised, I think is quite a good indicator of how our society is going. At least it helps to push if we can bring that figure down, it's pushing in the right direction. But then you need positive ones to try and measure what success looks like, where we can aim for. And I think those, again, are going to have to be experiential ones of the birthing person, and I would say, potentially controversially, also the birthing person's partner. Because in our society, we're embarking on parenthood in this very strange nuclear family. We don't have a lot of help. We're expecting these 2 parents to take this baby home from the hospital and, keep it alive and let it, do the right things and get it to grow. And I think that when we are just looking at very statistical, easily measurable metrics, we don't recognise the kind of effect on and the potential for good physiological births for both the birthing person and the partner. Oh gosh, so many questions. Right, I'm going to take one from here just because I've been going over here so far. I think that is a really interesting question. So the question of how do we help people be better prepared? Do we try and paint a realistic view, or does that compromise their outcomes later on? So I had an interesting discussion with a friend of mine who is Iraqi about miscarriage. So miscarriage is something that in our society we don't really talk about, right? It's something that we kind of often hide, and there's a lot of push to try and make people talk about it a bit more, because then when it happens to you, you don't feel like you're the only person in the world. So who that's happened to. But in Iraq, it's very common to talk about miscarriage. People do mention it. And actually, when my friend's sister-in-law didn't mention to her mother-in-law, my friend's mother, that she'd had a miscarriage, the mother was really angry. Like, how could you keep that information from us? But what's interesting, if we look at it from an evolutionary perspective, there is a societal benefit in sharing that information. So although it's a bit uncomfortable for the person sharing it, actually what they get reciprocally is that they get the knowledge from other people that it's happened to them. And once people stop playing that game and start to see it as something that is a taboo or not to be mentioned, actually they and everyone else then pays the cost. It's quite hard to then re-establish that. But I think that it is important to normalise societal discussions, not only about miscarriage, but also about pregnancies births that are not ideal, but also births that are ideal. I think we often have a very one-sided picture, where if you're pregnant from the NHS, what you receive is a lot of, this could be really good. And then what you hear societally is this is going to be really bad, this is going to hurt. And then we end up somewhere where we've got a very distorted view. Yes. Absolutely, I think there are a couple of points on that. Firstly, I've worked on quite a lot of lambing farms, and we do typically do a little bit more. But you're absolutely right; it's a very different level.
Lamb face.
Sorry,
I've never seen a master make it.
Oh, so I mean, I've done mouth to mouth just directly, and I've done it with piglets as well. And you can get kind of bag ventilators that we'd use in small animal hospitals. But you're absolutely right. I think there's definitely something we can do more of. I think the sort of converse piece is that often we don't detach the babies from their placentas, and I know that's something that is actually, in medicine, we're starting to look at how do you do resuscitation with an intact cord, because we recognise that 30% of the blood volume is in the placenta. Now, I can't tell you that vets actually have that understanding. We just don't usually cut the cord for quite a while, so potentially it's just, happenstance and mistake. But I think you're absolutely right. For certainly in production animal systems, neonatal care is not what it could be. Yeah, so you, and then I'll ask you.
I was just going to briefly comment on the neonatal resuscitation. I'm a vet and was in mixed practice for a lot of years. I think the main difference between that lamb and a human baby is that the lamb, perhaps sadly, is a production unit. So we could apply all that is possible in terms of neonatal resuscitation to that lamb. All that we can do for a human baby, we absolutely could do for that lamb, but it is going to wipe out any profit was in that production unit.
I wasn't proposing intensive care.
But there is a cost involved in doing it, and over many years of that farmer producing lambs and the vets helping that farmer deliver lambs, we kind of get to learn what works and what doesn't work. And more often than not, in a lambing shed, there is a small amount that we can do. We can certainly do mouth to mouth. We do bag them sometimes. There are all sorts of little medical interventions that we can do. But more often than not, if that lamb is just not viable, there is sadly little point. On the other hand, in a small animal hospital setting, with a litter of puppies that's delivered either by caesarean section or vaginally, there is an awful lot more that we do, because then it is not just hopefully it's not just a production unit. There's much more emotion involved in that birth than there is in the lamb on the farm. They're two quite different things that we're comparing, I think.
So I was more thinking just 10 minutes, the first 10 minutes in that lamb's life could make all the difference.
There's an awful lot that we do, and I've not seen that particular thing on Country Farm and the like, but certainly, and the vets in the room, the vet students in the room will have done an awful lot of lambing. And we'd spend an awful lot of time blowing down their throats, doing cardiac massage and all sorts of things, albeit it's just us and our hands, because more often than not we're there 2 o'clock in the morning and there's you and whatever you can carry in the pickup truck, and that's about it, rather than in a hospital setting. If a farmer was bringing you into a hospital setting, then there is a whole lot more intervention that we could do, but of course that has all of these negatives that go with childbirth away from where they want to give birth.
Isa. Yeah, it's a good point. So I'd say that a lot, as a group in this room, we're probably not representative of society in general. So I'll say what I've done, because I suspect that's probably quite similar to how you think, but I think there are also things we can do at a different level. So I just ended up reading lots of things. I read a lot about some of the from the early pioneers of so-called natural childbirth, which, I mean, basically they're trying to get towards physiological births. So I read quite a lot of that. I read lots and lots of really good birth stories. So things where you had a description of what was happening, but the impression was positive and things went well. Because certainly having something that you've got in your mind, when you're feeling a little bit worried or you're anxious, the default thought is then positive. The other thing I'd say that I think is particularly useful is there are quite a few Facebook groups for pregnant people, especially ones who are thinking about having births at home. The only reason I differentiate those is that there's a bit of a selection bias for the people who are in those groups. But you get people from very, very different socioeconomic classes who are contributing. You can see that because, of how they write, for example. But having lots and lots of different stories that you can relate to does kind of recreate some of that cultural knowledge that I think we've lost. Such a good question. I don't know. I think that certainly other people sharing experiences and being honest about the fact that, when most people, if they're having a baby, work really hard because they want the best for that baby. You know what? That is a question that has slightly stumped me, but I think it comes back to better societal communication of what has happened to other people and reassurance that sometimes we just don't know. So when I lost my baby at 20 weeks, we had a full post-mortem done. I'm a vet, so I was like, gosh, all the communicable diseases that I might have got, all the zoonoses, all of these things that could go wrong. We had a whole battery of tests and nothing. And actually, in some ways, that was probably the best outcome, because I was like, well, it just happened, and it doesn't mean that I'm at any higher risk going forward. I just kind of have to, go back to square one. So I think it is about communication. Yes. Yeah, I think that's a really good point, and it's something that that people are starting to look at this in the literature, looking at kind of, obviously we can't really, well, there are not many researchers who are still going to be in the same field doing research 21 years later, so the kind of randomised controlled trial pattern doesn't work so well. But I saw a paper that was published about 6 months ago that looked at the acute stress response in students who've been born by caesarean section versus students who've been born by spontaneous vaginal delivery. And they looked at stress responses in a kind of laboratory stressor system, and also looked at how they dealt with exam stress as a kind of naturalistic stressor. And what they found that was quite interesting was there weren't significant differences in microbiome, which is obviously the one that we often think about, and there's quite conflicting evidence to say either way. But there did appear to be significant differences in the stress responses. So one of the hypotheses there is that actually exposure to the right sort of bacteria at the right time of development can have longer term outcomes. The problem with this is that the layers of complexity just keep getting bigger. So I think that at the moment we are going to be limited to studies like this where we go, right, we're going to have to ask a question of these adults and look back and see if we can find differences. But actually our understanding of the processes involved in that outcome is very, very limited.
Well, they're very good long-term, but many studies just look at long-term outcomes, which is one of the most powerful tools for working out if interventions work. Short-term physical control studies are very difficult about and have lots of confounders. And of course, you're never going to get the ultimate here, which would be a twin study. Deliver one by stereosection. Just long-term descriptive data would be very useful. Mortality, education, attainment, etc.
Yeah, absolutely. I've seen some people trying to back out information on inductions, so on elective inductions versus spontaneous vaginal deliveries, and people are starting to do those kind of population cohort studies, which is yielding some really interesting information because the randomisation and the population selection for randomised controlled trials is pretty challenging. But I think it's still fairly in its infancy, and I'm not sure. I don't. Maybe it's because people didn't know that they are still only learning they have to be asking these questions. So I think it's I think it's a whole area of interesting untapped potential. Yes. Absolutely, and I think there's one particular piece that links to, which is the kind of the continuity of care aspiration that health services have been talking about for a long time, but thanks to the chronic underfunding and the crisis in maternity services, isn't being met. But this is the idea that right through your pregnancy, you see the same midwife, and hopefully, they're even there when you give birth. And because that does have very, very, very demonstrable benefits on a woman's experience and her birth process. And actually, I did experience that. So if we think back to when I was having the induction with the baby that died, I had to go to the hospital and I was sitting on this bed and I was in absolute floods of tears because I was so scared and I was so, so upset. And this midwife came in and she said, "Oh, you've got a little daughter, haven't you? And you've got pictures of bugs on your wall." And by some incredible coincidence, she'd been a student at my son's birth 2 years before, and it made all the difference in the world. So I think that, we underestimate that kind of very human need that we have at this very vulnerable time of our life. We really underestimate how powerful the effects can be. Great question. So there are a couple of points here. One is that the kind of prenatal, the pre-birth oxytocin surge in helping the fetal CNS to withstand hypoxic insults has only relatively recently been identified, but it's one of the reasons that they think that induced births have higher rates of hypoxia, not just because of those uterine contractions, but also you may potentially have a fetus that is less able to cope with it. So I would say that certainly around the induction side of things, that is negatively associated with fetal hypoxia. I suspect that with physiological births, if they are set up as they should, and you have a care provider who is able to unobtrusively monitor and respond as necessary, certainly the evidence on home births is not that they're associated with higher risk of cerebral palsy. So my expectation would be more physiological births would mean a lower rate of cerebral palsy.
Yep, so in the interest of time, we'll stop there for questions. But yeah, if anyone has any further questions for Gwen, feel free to ask her later on in the foyer. But once again, thank you so much for such an amazing talk.